Okay. Hello, my name is Todd Carter. I wanted to give you a little bit of information about myself before we start this. I am a assistant professor of pharmacy practice at the university. Actually, it's Appalachian College of Pharmacy. We started out at the University of Appalachia. I had a rename. I have no disclosures to give as far as any of the products that are listed in this continuing education. I am being paid for my presentation, but none of the products are the people who are paying me. So I am from Hazard, Kentucky, and I realize that a lot of you will probably be from all around the country and potentially around the world. I welcome any questions. I know that this is a pre-recorded CE. I have listed my contact information in the chat window, and if it's not available to you at this point, it will be later on, and the moderator will make sure that you get that. But my email is listed, and you can email me a private question if you don't want to ask in front of everybody in the world. Also, I have included a Google document link that you can add your question to if you would like, and anyone who has access to this CE will have access to that question, and that way I can answer it for everyone to see. So, born and raised in southeastern Kentucky. I went to the University of Kentucky in 1996, graduated in 2000 with a PharmD. I have an ambulatory care rotation in Hazard. One personal thing I always like to get out up front is I have a very visible tick. Your screen is not glitching. You're not losing connection. That's just me. So, sometimes it's a topic for discussion. Sometimes it's, let's not talk about it. So what we're going to talk about today is women's health, what's new in primary care. And I want to give you guys a little insight on some pharmacy point of view. We're going to talk about some drugs. Some of them are new. Some are still in development. And we'll go from there. So objectives: I want to be able to discuss the changes in current medications prescribed for women in primary care, distinguish pertinent pharmacokinetics for those medications, and also interpret some of the clinical applications for those medicines that are used. So what we'll cover specifically, we will talk about pregnancy categories and how that has changed for drugs and drug labeling. We will talk about Dyspareunia. Specifically, we'll talk about Ospemifene, libido with Addie or flibanserin, management of menopausal symptoms, and also osteoporosis. Another thing that I like to, I guess as a disclaimer, give when I first start talking about these is I'm the type of person that believes in giving the complete, full, and truthful information when it comes to medications. Sometimes it's positive, sometimes it's not positive, and I consider myself a barrier between patients and drug companies and between providers and drug reps. I'm not anti-drug rep, don't get me wrong, but when someone has something to sell, they'll often focus on the more important parts, maybe glaze over on the stuff that's not so good. So we'll talk about some things and some of the shortfalls of them, and especially when we get to Addie and some of the information that's on it. So, okay, pregnancy and lactation labeling rule, or the PLLR. This is relatively new. It is still being phased out. The content and format of labeling for human prescription drugs and biological products. Mind you, everything has to be stated specifically. This is for human prescription drugs, so this is not going to affect all drugs or all chemicals. This was issued by the FDA in December of 2014, and it's going to change the way that drugs are categorized for pregnancy. It requires removal of the categories A, B, C, D, and X that we're all familiar with on human drug and biological product labeling. And the reason for this is oftentimes it is viewed as being confusing or overly simplistic. It doesn't effectively communicate the risk that the drug might have for pregnancy and lactation. And also, most of the time, there's no consideration or mention of males of reproductive potential. So we'll get into that in a few seconds here. Prescription drugs and biologic products submitted after June 30 of last year, 2015, will use the new format immediately, and things that were approved on or for June 30th, 2001 will be phased in gradually. So it requires a change in content and format for the information presented. And this is meant to assist you guys in being able to assess the benefit versus risk in different products for pregnant women and for counseling those nursing mothers who need to take medication. Allows you to give informed and educated decisions by patients as well for themselves as well as their children, and also requires labels to be updated when the information becomes outdated. So, advance here. Here is a slide of the current labeling, and it shows the 8.1, 8.2, and 8.3, where we have pregnancy, labor and delivery, and nursing mothers. The new labeling will have pregnancy, which includes labor and delivery, lactation for the nursing mothers, and then a new section, 8.3, will be females and males of reproductive potential. So 8.1 has that information for a pregnancy exposure registry for pregnant women. And the exposure registries collect and maintain data on effects of approved drugs that are prescribed and used by pregnant women. So information about existence of any pregnancy registries and drug labeling has always been recommended, but it's never been proven. And when we see different regulations and changes, I often point out that these things have to be done at one point. They have to be stated. And it's always been recommended, but at this point, it is actually required, which makes it a good deal. The information in the pregnancy subsection also includes a risk summary, clinical considerations, and data. And then the information that was formerly found in the labor and delivery section is now in the pregnancy subsection. So, advance here. I apologize. The technology doesn't always respond when I want it to. Nursing mother subsection was renamed lactation subsection, and this will give you the information about drugs that are used while breastfeeding. Sometimes we focus so much on pregnant patients that we forget to remember that so many drugs will actually pass into the breast milk, and not only if they do, but the amount that will, and then for the potential of effect on the infant. Now, females and males of reproductive potential, this subsection is probably the most important because it is the newest. This will give information about when it's necessary for pregnancy testing, contraception recommendations, as well as info about infertility as it relates to the drug. This was put together this way to give a more consistent format and location for information. Oftentimes you would have to look in two different sections in order to get this information, and for consistency's sake and ease and comprehension, it puts it in one place. So that's good. Labeling for over-the-counter medicines will not change. This is only for human biologic prescription products. So that's an important thing to know. So that's essentially the change with the pregnancy and lactation labeling. You can go to fda.gov and view the entire guidelines. But what I've summed up in these slides is enough to pretty much label it all. So just like newer terminologies, I still hear people say STD instead of STI. Every now and then ICD-9 will slip out of somebody's mouth instead of ICD-10. So you'll still hear the pregnancy category A and B as we transition, but this is what it should be going to, and the newer medications will have these labels instead. So Dyspareunia. This to me is an important topic because I feel that oftentimes it's something that is overlooked. And I teach pharmacy school, and one of the things that I tell my students when I first graduated, a lady came up to me in the pharmacy, and she was an elderly lady. She was probably in her 70s. and she asked me what was the best product for vaginal dryness. And I remember afterwards thinking that this lady came up to me, not knowing me from anybody, and asked me such a personal question. And it really struck to me the impact that I can have on patients. And dyspareunia, or painful intercourse, is something that could be perceived to be very embarrassing to some people to talk about. And another thing that I focus on in my lectures is mass communication or advertising and media. This product has actually been advertised on television and on the internet for the last several months or year or so. And the more advertising that these products get, the less stigma that they have, the more chance that, people are going to come in and actually talk about it. So it's something that I know you all are familiar with, and it's something that you've dealt with in your practices before, but it's something now that I think you're probably going to be dealing with more often. And I have actually looked at some of the curricula in different pharmacy schools, and when they talk about women's health, even though we have a medication for this, it was not mentioned. So this is something that you're going to see more and more of. So again, recently advertised, that'll lead to decreased stigma and more inquiries from the public. Many women experience dyspareunia at some point, as many as 1 in 3, as a matter of fact. Defined as a persistent or recurrent genital pain that occurs just before, during, or after intercourse. And actually, the deputy director of the Office of Drug Evaluation from the FDA said it is among the problems most frequently reported by postmenopausal women. So it can occur for a variety of reasons, anything from structural problems with endometriosis and scarring or pelvic inflammatory disease to actual, psychological concerns from stress or depression and other things. So it is associated with declining levels of estrogen hormones during menopause. Vaginal tissues thin, they become drier and more fragile. Symptoms, you actually can have pain at penetration or entry only, with every penetration, sexual or otherwise, whether it's premenopausal women with using tampons or anything, even in patients who were previously pain-free, those who develop deep pain during thrusting, burning, or aching, and sometimes it can last for hours after. So, topical estrogen creams had actually been the conventional therapy for a long time. And this is where I want to talk a little bit about drug names. And I want to ask the audience here with me, do you know how Premarin gets its name? Neither one. Excellent. I know there's probably some of you listening to this saying, I know. Shame it's not a live CE. So pregnant mare's urine. Okay. So what I didn't know, I knew that it went back pretty far, but actually in 1930, there was a discovery of Eminen, not M&M. M&M is a candy or a wrapper. But Eminen was the first orally active water-soluble estrogen. Before that, they actually had to use human steroids that were injected. And they made those by extracting the estrogens from the late pregnancy urine of Canadian women. So this was labor intensive. It led to a lot of costs. So they were looking for something that was lower and potentially more potent, so they wouldn't have to use as much. And in Berlin, there was a zoo. They were studying the urine of pregnant equines, not just horses, but also zebras. And they found that there was significant quantities. It was potent, water-soluble, and conjugated. So Arist, drug company Arist in 1939, actually found a way to extract that. And it ended up being developed and approved in Canada in 1941 as Premarin, or pregnant mare's urine. The following year, it was approved in the United States. So it's been approved since 1943, so since World War II. Okay. Now, there's been all kinds of debates, and that's not what the purpose of this continuing education is about, whether it's obtained humanely or you should use this versus using natural estrogens. And we may do that in a different CE if we do HRT or ERT. But estradiol, which is the other, or estrase, is a human synthetic estradiol, and it's also combined with with phytoestrogens from yam and soybeans. So that has what was been used in the past. Vaginal lubricants may be used if it, in minor cases, especially if it's stress related. Vagisil and Replens are two of the more common ones. Desensitization therapy. Patients can use vaginal relaxation exercises that help to decrease the pain. I'm sure these have been recommended by some of you in your practice. Pelvic floor exercises like Kegel exercises, and they will help to decrease the pain with intercourse. And then, of course, we get to my point, which is Ospemifene. And the reason I think that the Dyspareunia is so important, I guess they say the devil's in the details. Things that I like to focus on is not, you can have a skyscraper and people will focus on the 100th floor. But what I look at is the foundation that it's built on. And if the foundation's not strong, the whole thing will come down. And two things that I always focus on is quality of life and restful sleep. If you don't have restful sleep, it can throw off everything, including your quality of life. But human beings are sexual in nature, and to have something that that causes a problem between you and your partner can affect all facets, and it's embarrassing to talk about. And that's what I think that it's important. And I know most of you have already dealt with this in the past with maybe some of these previous therapies, but we want to talk about Ospemifene today. So it is a tablet. Ospemifene itself is an estrogen agonist or antagonist, so it will have positive effects, estrogenic receptors, and they'll also have antagonistic effects in some tissues. And that leads to some of the side effects, and we'll talk about those here in a second. So safety and effectiveness was established in 3 clinical studies. If you'll notice, the study has 1,889 people in it, which is a good sized study. And these were postmenopausal women with symptoms of either vulvar or vaginal atrophy. After 12 weeks of treatment from the first 2 trials, showed a statistically significant improvement. And this gets my other soapbox that I'd like to get onto. I'm sure you guys are all familiar with drug reps and studies. There's a new study every single day. There's actually a meme that says, a study says that I can get you to believe anything as long as I preface it by saying a new study says. But not all studies are what they should be. And the fact that this says statistically significant, we go over these things in school, and then in practice, we focus so much on taking care of our patients that sometimes the nuances of these trials can get skipped. And statistically significant means that you are reasonably sure, scientifically sure, that this effect is actually caused by the intervention, and then the intervention being the medicine that you have given. And they showed after 12 weeks of treatment and these first 2 trials that there was a statistically significant improvement. Results from a 3rd study showed long-term safety, which is another thing that's important, because if it improves but is not something that you can have long-term care for, then we have an issue. So we have to show not only that it helps to improve, but it also has long-term safety. Should be used in the shortest duration possible, consistent, of course, with the treatment goals, and then the risk for each individual that is actually on the medication. So there is a black box warning, or boxed warning is anymore is what it's referred to. Can either of you tell me what a black box warning is?
Well, you handle that
So both of the people in the room are throwing things at me. I don't know if you saw one just fly by. Okay, that was my pen. But a black box warning, as stated by the participant, is that it is a significant warning. This is when you have a serious or life-threatening adverse effect. Once you have a black box warning, you are then required to give a med guide. The magic behind the name of a black box warning is the information consists inside of a black box. Okay, so there is a black box warning with Ospemifene or Ospemifene. Use of unopposed estrogen in women with an intact uterus is associated with an increased risk of endometrial cancer. Again, at this point, we're stating something that seems somewhat obvious in today's terms, but just 15 years ago when I graduated from pharmacy school, you were on HRT for the rest of your life, as long as you could possibly take it because of the cardioprotective effects. And then, of course, as we observed the cancer rates, and now that has been changed. Medical information is constantly evolving. But this is now stated. We now have absolute proof, and it is a black box warning, and it boils down to benefit versus risk. Addition of a progestin to estrogen therapy may decrease that risk of hyperplasia, which of course is a precursor to endometrial cancer. Adequate diagnostic measures, including endometrial sampling, if it's indicated, should be performed to rule out malignancy. It is, as I stated, an agonist and antagonist, so it has agonistic effects on the endometrium. Women that have an intact uterus using an estrogen without a progestin do have that risk of increased cancer, and that is dependent upon dose and the duration of therapy, as well as the response of the patient themselves. So, using data from the Women's Health Initiative or the WHI studies, an increased risk for DVT or deep vein thrombosis and stroke have been reported with oral conjugated estrogens. So most of this risk is well understood by most people. Even laypersons understand that the risk is here. But in a sue-happy society, you have to always make sure that you have your stuff covered legally when it comes to these things. We have kind of a standard joke in pharmacy school about 1-800-BAD-DRUG, where you can sue for typical side effects that come with medications. So when you have something as bad as DVT and potential stroke, you have to really make sure that you counsel the patients. Don't scare the patients, but make sure that they're very well informed on what the risks are, and then have that well documented. So following with Ospemifene clinical trials showed a thromboembolic stroke 0.72 out of 1,000 women versus placebo's 1.04. That's one thing. And then 1.4 for hemorrhagic stroke versus 0 in placebo. And then DVT 1.45 or 1.04. So thromboembolic stroke was not so much of an issue as the hemorrhagic was in DVT. So risk factors, comorbidities are always something that we need to consider when we're managing something like this. Risk factors for cardiovascular disorders and arterial vascular disorders should be managed appropriately. Of course, these risk factors include diabetes, hypercholesterolemia, hypertension, lupus, obesity, etc. Sometimes people will glaze over. They hear so much, you shouldn't smoke, and then they kind of glaze over it. And this would be an important point to sit down and say, listen, this is a risk. This is something that could happen, but we don't want to add any more that we could to add to those risks. So being able to control those comorbidities is an important factor in helping to prevent the potential side effects with this. Discontinue immediately if a VTE or thromboembolic or hemorrhagic stroke occur, or if they are suspected on any level. So do not use estrogens or estrogen agonists or antagonists concomitantly with Ospemifene. Fluconazole, diflucan, commonly used for vaginal yeast infections, is not to be used with Ospemifene. The details I'll leave out, but essentially it increases serum concentrations, and in doing so, it would be the same equivalent as increasing the dose. So do not use rifampin for the complete opposite reason, because it will decrease. So with fluconazole, you're going to increase your risks for bad side effects. And then with rifampin, you're not going to get the therapeutic effects because the concentrations will be lower. So the next is libido, and this is probably one of the more unique times that you'll get to talk about this particular drug, because it absolutely is the first of its kind. I've heard information at some seminars that I've went to on it. These days, the trend with medicine is everything needs a good acronym. Okay, so we have hypoactive sexual desire disorder, HSDD. You may or may not have heard of low T, OAB, IBD. It's enough to say that low T may lead to OAB or IBD, so see an MD ASAP or an ARNP. Okay, a little alphabet soup. Hopefully you're laughing. Hope you're not tuning out saying, "Oh Lord." But people will hear these terms and then they'll come in. So it's very important that we are familiar with them as well. So low libido or low sexual desire, we obviously are familiar with that, but HSDD is somewhat of a newer term. Defined as a deficiency or absence of sexual fantasies or desire for sexual activity that causes significant personal distress or interpersonal difficulty. Now, this is something that I don't want to glaze over, because I think this is important, and it's important the same way when you're dealing with students, or if you're dealing with patients and you're reading off when drug commercials advertise, do you have a lack of interest? Are you tired? And they'll have 2 or 3 symptoms and they're like, oh my God, I have major depressive disorder. And HSDD is defined as the deficiency or absence of sexual fantasies and desire for sexual activity that causes significant personal distress. This is not someone that, just not in the mood all that often or whatever. This is someone that is causing significant personal distress. And people may ask about it. More than likely, they will not. I'm sure most of you probably cover these in your screenings, but this is the type of thing that, you may need to approach and say, is everything okay relationship-wise? Do you feel that there's any, issues as far as sexual desire? Because people may be hesitant to bring it up. The WISHES study in 2006, which is the Women's International Study of Health and Sexuality, assessed the prevalence of HSDD and how it affected quality of life in U.S. women, and based it on their reproductive status and age. They found that 24 to 36% of women between 20 to 70 had problems with low sexual desire. And it also, that the percentage of younger surgically menopausal women, 20 to 49, was significantly greater versus premenopausal women, which makes sense, of the same group. Ultimately, though, when all the data was considered, it said that HSDD is prevalent among women of all ages, regardless of their reproductive status. Younger women who are surgically menopausal are at the greatest risk, and that's where I think that it would be appropriate to counsel and to proactively ask if there's any issues. And with each screening, it may give them someone kind of break down the barrier and give them a chance to bring that up the next time. So before I move on to Addie, I want to go back real quick, and all of these will be available for you. And there is a guide for Ospemifene. We'll look at it right quick. And this is a PPI, which is a prescribing patient information. So it's prescribing information, but it's information that is less technical for the patient. Allows them simple things as being able to pronounce the drug appropriately. And then you can see on here that we have the black box warning, and it gives that warning in this area. Says that it does increase your chance of getting a clot and strokes. This is to be given to the patient either at the pharmacy or it can be downloaded online. It would be best in order to cover your bases if you gave it out as well. Pharmacies do have this information and do give it for patients that are on this drug, but it goes over, smaller things like what is Ospemifene, what is it used for, that's a little polling question you can answer to yourselves. What level should a patient information reading level should it be geared towards? 5? Fifth grade? Do you agree? 3rd grade? Well, we have one person wants to make sure that you get as many people as possible to understand it. How many people have ever looked at a package insert for a drug or a patient leaflet that is given by some of the larger chains, which I won't name? But if you look at that information, the law says that you have to provide patients with the information so that they're well informed. It doesn't say that they have to understand it. So we have in education, we want to make sure that everyone understands. But when you're looking at, I guess in the world of practice, they're looking more to cover their bases. And some of those leaflets are so confusing, and they have terminology that is PhD level terminology. What I like about the PPIs is that they have appropriate information, but they are broken down a lot easier for patients to be able to understand. So again, it has who should not take Ospemifene. We'll go back up to the top here. It continues. What should I tell my healthcare provider? Tell your healthcare provider about all the medications. How should I take it? All of this should be covered in the pharmacy, but you want to make sure that they're able to see it here as well. And sometimes, you may bring something up and someone may want to think about it first. And you can either give them this information or refer them to the Ospemifene website. And there is a tab for patients, and then there is a tab for providers. It gives some of the side effects, the less serious ones. What can I do to lower my chances, which is, can back up your counseling. How should I store it? Just all kinds of general information. So that's good. I wanted you to see that. And then let's go back here to Addie. Give me just 1 second. All right. And I've lost my presentation. 1 more second, please.
Which
the default. Okay.
This one here.
Yes, thank you.
There you go.
So Addie is the first of her kind. And Addie has been called the female Viagra. I have seen it pronounced Addie, Addie. It is not. Take it from the authority, which is myself. It is pronounced Addie. Addie being called the female Viagra. I have an issue with that because I don't know how many people in the audience are old enough to remember the Primatene Mist commercials. Have you guys seen the Primatene Mist commercials? They have a little stopwatch, and they'll take the Primatene Mist and then they'll go, psh, and then it'll count down in 15 seconds you get relief. But it shows them giving 2 puffs at the same time, which in pharmacy we know means they get 1 puff. Because when you do 2, just like with an eye drop, if you do 2 drops at one time, 1 drop just tears out. Okay? So starting off with the female Viagra gives it the wrong idea, because Viagra is taken in a whole different manner than Addie. Oftentimes the media will grab a hold of things. When Prozac first came out, it was called the happy pill. Prozac does not make people who feel normal happy. It helps people who are depressed feel normal. And the comparison of that could be described as happy. But it's still called the happy pill by a lot of people, and that's not the way it works. And calling this the female Viagra is also not a good deal. So Addie or flibanserin is indicated for the treatment of premenopausal women with acquired generalized hypoactive sexual desire disorder, HSDD, as characterized by low sexual desire that causes marked distress or interpersonal difficulty and is not due to a coexisting medical or psychiatric condition, problems with the relationship, or effects of medication on other drugs or other drug substance. Now, I also teach men's health to pharmacy students, and when we talk about erectile dysfunction and we talk about Viagra and some of the other drugs, one of the things that we talk about is psychogenic ED. And Viagra does not put a man in the mood. It allows a man in the mood who has physical issues to be able to perform. So Addie works the complete opposite way. Addie does not help anyone to perform. Rather, Addie puts people in the mood. Okay? So if you have hypoactive sexual desire disorder, that's one thing. If you have an issue with your boyfriend or your husband, that is another thing. And Addie's not going to fix that. So there's actually a screen that I'll pull up here. It is a decreased sexual desire screener. And this is something if you decide to dispense or rather prescribe Addie that you need to have in your office as a tool. And each question is answered with a yes or no. In the past, was your level of sexual desire or interest good and satisfying to you? Has there been a decrease in your level of sexual desire or interest? Are you bothered by your decreased level of sexual desire or interest? Would you like your level of sexual desire or interest to increase? And then please circle all the factors that you feel may be contributing to your current decrease, and an operation, depression, injuries, other medical conditions, medications, alcohol, which is extremely important, we'll get to in a few minutes, pregnancy, recent childbirth. As you well know, this can affect your hormone levels and it's a temporary issue. Other sexual issues, your partner's sexual problems, etc., etc. So if they have dissatisfaction with the relationship or partner, this is not a fix. And people have this idea that men who take Viagra are always in the mood, and that's not the way it works. And Addie is not a fix to a larger problem. If it is hypoactive sexual desire disorder, then we will work. Let's see if I can switch back to my primary. Moderator, please fix me again. I apologize. This is going to happen a couple times, and I'm not sure what I'm doing wrong. It's probably
right here.
Yeah, got it. Okay, so limitations of use. It is not indicated in postmenopausal women. It is not used for use in men, and it is not indicated to enhance sexual performance. Again, this is a distinction between Addie and Viagra. If a man does not have erectile dysfunction and takes Viagra, then they can actually enhance sexual performance. The single most brilliant piece of drug advertising ever in this entire world, probably ever will be again, if you experience an erection lasting more than 4 hours. That's all people hear is a 4-hour erection. And I'm not sure if it was meant to be that way, but that's kind of what sticks with people. Addie is not something that can be used to enhance performance. So not what we were intending. This is one of my favorite things to talk about when I talk about medications and what they're used for. What kind of drug, audience, is Phenergan? What class of drug is Phenergan?
Antiemetic.
It's an antiemetic. That's what it's used for. What class is it? what is it actually? Drug is actually an antihistamine. It's just not a very good one. Okay. When we think antihistamines, we think allergy. Of course, we're not going down H2RAs with stomach acid, but when you hear antihistamine, which is the antihistamine that it is, it's not a very good one. Okay. So what about Rogaine? What is Rogaine? What it classes Rogaine? It's a hair drug, which for the audience, that is not an actual category of drug. It is an antihypertensive. It's actually not an awesome antihypertensive, but it does have a side effect of regrowing hair, something that I don't know anything about. What about Viagra? Viagra was used for angina and still is. Okay. What about Zyban? What is Zyban? Zyban versus Wellbutrin. Zyban is a smoking cessation aid, but Zyban is actually an antidepressant, bupropion. Okay, so people who were taking bupropion, actually, they did a comprehensive study or comprehensive questionnaire when they started, and do you smoke, et cetera, et cetera, et cetera, and they noticed that a large number of people who previously smoked while they were taking this for depression stopped smoking, and then it led to that. So that's where we get with Addie. Addie was not intended to be for hypoactive sexual desire disorder. It's actually an antidepressant. Again, not a very good one. So it's really easy to be caught off guard when people ask you about things that are counterintuitive to the indication that you would think. For instance, Phenergan being an antihistamine. Especially in today's climate of using drugs for off-label indications, right? So what is the first thing that comes to mind when you want to talk about diabetic neuropathy? What could you use for that? Gabapentin, Neurontin is absolutely not indicated for that. It is an anti-epileptic. It is a seizure medicine, but it is prescribed more for diabetic neuropathy than anything. So I come in, pins and needles in my foot. You say it's because I'm diabetic, et cetera. So you give me the medicine, then I go home and I read it, and it says blah, blah, blah about seizures. That's going to freak somebody out and think that you don't know what you're talking about. And then they call and the office is closed and they're all panicked. And then you're going to deal with that the next day. So it's important to, in your counseling, to include this information first so that you don't have to deal with those kind of questions later. I remember at one point, and they say that hindsight's 20/20. If a mountain, a mountain saying is that the problem with learning by experience is the experience comes before the learning. So I tried to pass my experience on to my students, but I had a patient come up to me and say, "What's Phenergan for?" And I said, "Nausea." And he said, "Okay." And then he left. The next day, my partner at the pharmacy calls me and tells me that I have a doctor online who is threatening to call the board of pharmacy for me intervening in the therapeutic process between him and his patient. And I said, "I have no idea what you're talking about." So I called the doctor, and the doctor said, "What right did you have to tell my patient that what I prescribed for him is not what it's for?" And I said, "I didn't tell anybody anything other than he asked me what Phenergan was for." Phenergan in high doses in other times was used for psychosis. It could be. And we're talking, really high doses. I don't think it's even listed as off-label use anymore, but it had been. And it was, the patient had not responded or had side effects to other medications. So that's why they had eventually come to this. It wasn't first-line therapy. But if he come up to me and said, "My doctor put me on Phenergan for psychosis," does that sound normal? Then I would have looked that up. So I have learned that when someone says, "What is Phenergan for?" then I say, "Well, it depends. Why are you taking it?" So little things like that can actually save you a lot of heartache. Diphenhydramine, Benadryl, is an antitussive. It's a very good antitussive for children. It's not strong enough for adults. Most of the time you won't see it listed as an antitussive, but most families will have Benadryl for one reason or another. And a lot of times if there's no contraindications, that's a good thing. So it's real easy to be caught off guard when patients ask you about things that don't exactly match up to the paperwork. So the availability of information on the internet, I'm not sure how many of the audience actually has Facebook, but there's a meme that says your 5-minute Google search doesn't, equivalent. How long is your degree? How long is a doctor of nursing degree? 4 years, 3 years, 6 to 8. So it depends on who's listening and if you're a certified family nurse practitioner, et cetera, et cetera, et cetera. Varying degree, but just insert your education. Your Google search doesn't equilibrate that. And one thing that I always had to fight before the internet was a book called The Pill Book. And the pill book listed most of the major medications and their side effects, but they were not held to the standard to list them in a way that made sense. So the number 3 listed side effect for ibuprofen was coma. And I've been in pharmacy for 20 years and I've never known anybody to go into a coma taking ibuprofen. I'm sure if you took a couple bottles of it, it would probably happen. But there is a glut of information on the internet, and patients will get information that's not always as accurate as it should be. So it's good to be able to think about this before it actually happens, and to be able to deal with these type of questions. And again, Zyban, Phenergan, and Rogaine are the 3 that we talked about. So, Addie development. Another thing about Addie, and I think this is important to know as well, because there's some history that's somewhat confusing on Addie. It was originally created as an antidepressant. After testing, was not found to be very effective as an antidepressant. Again, just as we discussed with Viagra for hypertension and angina. While females were being questioned about their trial experiences, side effects, etc., a large number noticed that they had a positive side effect that was unintended. They discovered that they reporting more sexual interest, overall satisfying sexual experience than before. And it was actually to the point that some women didn't want to stop the trial based on this fact alone. Once this information was compiled, it led to them actually clinically testing for sexual desire. So the dose is 100 milligram tablet, and it is taken daily. It is not taken PRN like Viagra or Cialis. This is taken every single day, and that's one of the main reasons why I don't like the idea of calling it the female Viagra. It is dosed at bedtime because administration during waking hours increases the risk of hypotension. Hypotension and syncope is what actually puts it into the REMS program, which we'll talk about in a second. Accidental injury, central nervous system, depression, somnolence, etc. If a dose is missed, skip it. Do not double up on doses. Even though you hear that 99% of the time, there are some drugs that you actually do double up on. So because there are exceptions, we do have to say every time if you need to skip it or not skip it. If after 8 weeks there's no improvement in the symptoms, then it is to be discontinued. Taking at bedtime, there is brings up another kind of pharmacy history lesson. Covera HS was a verapamil product that was marketed years ago. And Covera HS and Estratest HS both have the same HS at the end. What does Covera HS stand for? So some people are thinking potentially do with bedtime. Then what about Estratest HS? Estratest HS, I'll tell you right now, stands for half strength. You want to stick with the bedtime?
No.
You should, because that's exactly what it meant. It was verapamil that was dosed at bedtime, And the reason it was dosed at bedtime is so that you could sleep through some of the side effects. Ester test HS stands for half strength. So don't ever rule out your pharmacist as an excellent source of this kind of trivia and information, because this is what we do in pharmacy school, is learn what the initials mean. And they're not always intuitive. They should be, but they're not. As a matter of fact, in over-the-counter medicines, they are used as a marketing ploy. Motrin IV is simply Motrin ibuprofen, which is what's in Motrin. So, but I thought that was relevant to bring up. It may help you to remember that it's dosed at bedtime so that you can get the daily dose, but you can sleep through the majority of side effects. So, contraindications, alcohol. There could not be a larger contraindication with this medication. And it's the whole reason that Addie is in the REMS program, which is Risk Evaluation and Mitigation Strategies. Probably two of the more popular REMS programs were Accutane with birth defects, and then with antidepressants in children under 18. So REMS programs are set up so that everyone is informed and documented about being informed. Hypertension and syncope. Moderate or strong CYP3A4 inhibitors dictate monitoring, and then if there is liver dysfunction, the use of Addie can cause severe hypertension, so it would be contraindicated in patients that have the hepatic issues. Okay, contraindicated in alcohol. This is a good example that I like to use. What is one of the most common side effects with ACE inhibitors? What would you counsel straight up? ACE inhibitor induced cough. Okay. Some report up to 30%, most 1 to 10%. As common as ACE inhibitor induced cough is, it's still less than a third. What about ibuprofen? Bleeding is one, but more common side effect, GI upset, right? 3 to 9%, right? Everybody knows, take ibuprofen with food. Hydrocodone, sedation, 1 to 5%. Okay, so when we get into the severity of hypertension and syncope with Addie, you'll see why that's important. So before prescribing Addie, you have to make sure that the patient knows to abstain from alcohol. Then you have to assess the likelihood that they understood that they need to abstain from alcohol and that they will abstain from alcohol. You take into account their current and past drinking behavior, other social and medical history, and counsel patients about the importance of abstaining from alcohol use. Alcohol risk increases the risk of severe hypotension. In an alcohol interaction study with 25 subjects, 23 of them men, 22 in premenopausal women, found that hypotension requiring intervention occurred in 4, which is 17%, and patients had to be who had 0.4 grams per kilogram of alcohol. I actually have stats on here how much that is. That's 2 12-ounce cans of beer, 2 5-ounce glasses of wine, 2 1.5-ounce shots of 80 proof alcohol. Now, the question that I had, and you very well should have as well, is if we're going to do human testing, okay, we can do animal testing, and animal testing can give us an idea, depending on what animal it is, whether or not it may or may not occur in humans. But Addie is indicated for who? Premenopausal women. So 23 out of the 25 subjects were men. Can you explain that? Can anyone explain that? If you're explaining it at home, I can't hear you, by the way, because this is pre-recorded. So we hear terms like phase 3 clinical trials, et cetera, et cetera. Sometimes we don't actually go into what is a phase 3 clinical trial. Phase 3 clinical trial is when in human trials to test for effectiveness and side effects, et cetera. But there are other trials, phase 1 and 2, that are used to determine other things. And actually, it was a phase 1 trial where they were testing not the effectiveness of the drug, they were just testing the drug's interaction with alcohol on the human body. So they needed someone who had at baseline 5 to 10 drinks per week. And this drug was actually studied in Eastern Europe, and they could not find a female population that consumed 5 to 10 drinks per week at baseline. So the study was done on men instead, because the mechanism of action will allow for increased sexual desire in women, but the effect of alcohol is the same on both males and females, even more so if you consider that females often have lower body weight, less tolerance to alcohol, and can react more. So the effect that you see in alcohol in men would actually potentially be exaggerated in women. So this is not listed anywhere on Addie's website or Addie's REMS or Addie's drug information. But when I see something like that, I always anticipate questions. And the question, if it's not indicated men, why was it studied in men? So I called and got the actual lead investigator from Sprout Pharmaceuticals, and we talked about it, and that's exactly why. So now let's talk about how much of a reaction that they had. So the magnitude of these reductions range from 28 to 54 milligrams of mercury in systolic and diastolic of 24 to 48. And so I took in a 120 over 80 patient. That would be a 45% drop in systolic and a 58% drop in diastolic. I was just seeing numbers, 28 to 54. That's not, but when you put it into that, which this is a potentially deadly drop in blood pressure. In addition, 6 of these patients that were co-administered Addie and alcohol experienced orthostatic hypotension when they stand. This is one of those grim but true facts, which some of my colleagues may already know. How far does it take to fall to be a lethal fall? It's like 4 feet to be a lethal fall. Now, I'm a 6 foot tall person, and people who pass out on movies, they always fall so easy. They just collapse into a little bundle. People who pass out for real hit their heads on tables. They crack their heads open on concrete. And orthostatic hypotension, you don't have to jump straight up from laying down. In this, with a medication like this, you can stand up and fall down, and it could put out an eye. It could actually be lethal. And because of the potential of this happening with people, this is where we get into the REMS program. So one of the subjects actually had to have ammonia salts and was placed in a supine placement, in a supine position rather. Mind you, if you'll notice, there was 25 patients, and the reactions that we had out of 25, that is an extremely high number. There were no events that required therapeutic interventions when Addie or alcohol was administered alone. So in all these people that reacted, they gave them Addie and they were fine. They gave them alcohol and they were fine. They gave them both, and then they had the reaction. Drug interactions, oral contraceptives and other weak 3A4 inhibitors, increased flibanserin exposures, strong 2C19 inhibitors, increase exposure, which may increase the risk of hypertension and syncope. Also, the CNS depression, remember when you're counseling people on this, you have to not only tell them to not take alcohol, but you also have to make sure that they understand that and are going to reasonably adhere to it. Digoxin increases DIG concentrations, which may lead to DIG toxicity. Probably not going to be a huge issue for patients in the population that this is indicated for, but potentially. So if you are initiating Addie following moderate or strong 3A4 inhibitor use, start at 2 weeks after the last dose so you have enough time for that to clear. If initiating a moderate or strong 3A4 inhibitor following Addie use, then you want to do at least 2 days after the Addie to give it time for it to be cleared enough that 3A4 inhibitor won't have an issue. 3A4 inducers like rifampin can actually substantially reduce the flibanserin concentration. Increased DIG concentrations, again, can lead to DIG toxicity. Other drugs like CNS depressants, hydrocodone and Xanax, even things like minocycline, which we don't think about, which could be more of a chance for the patients to have in this targeted population, are things to consider. Okay. So this is just a brief list of 3A4 inhibitors, strong, moderate, and weak inhibitors. We hear a lot about drug interactions, and a lot of drugs are thrown at us, but I put some of the ones that are more common. Grapefruit juice. Now, mind you, this is not eating a grapefruit. This is typically consumption of a fair amount of grapefruit, 8-ounce glass of grapefruit juice or more. Fluconazole falls in the moderate inhibitors. And then under the weak, you can see Xanax and fluoxetine or Prozac, Tagamet, cimetidine, Torvastatin, some of your more common drugs. So strong CY2C19 inhibitors increase flibanserin exposure, increase that risk of hypotension, syncope, and depression. And you can see some of the more common ones in here. And here's where we'll actually have the oral contraceptives. Even omeprazole, which is over the counter, is prescription and over the counter both, but that would warrant discussion. We're going to go over a couple of the handouts, and then we're going to take a small break. Let's see here. The Addie medication guide, we'll go over it first. So what is the more important information that I should know about Addie? Drink alcohol, do not drink on any level. Certain medications, what gives them, it also talks about not only prescription, but herbal as well as over the counter. If you've ever had liver issues, if you take it and feel lightheaded or dizzy the next day, hinting at orthostatic or just hypertension in general. It also tells them a little bit about Addie, what it's for, and who should not take it. And okay, so who should not take Addie, and this gives you a more extensive list, and you'll see most PPIs do not have, this is a 4-page PPI, and most PPIs are 1 or 2 pages. This is one of the longest ones that I've ever seen, and it has a lot of drugs listed, and if you'll notice, it also lists them as brand and generic. Fluconazole, diflucan, Cipro or ciprofloxacin. That's important. We still use brand names a lot. You won't hardly ever see a generic drug advertised. Brand names are what are advertised, so that's what people know. What should I tell my doctor before if I drink alcohol or use drugs? A lot of times people think that you're going to be judged. You know, I drink alcohol. Well, they're not going to think you're an alcoholic. So it's important to emphasize that the severity of the interaction here, and this is not to judge someone, but rather to mitigate the risk. How should I take? Tell your doctor the medicines you take. How should I take it? What should I avoid? What are the possible side effects? Sleepiness and low blood pressure, you'll see are on here, more common ones. And Then we follow up with how should I store it, and etc. So that is the actual PPI for patients. And I haven't put the prescriber enrollment form on here because this is what you will actually have to do in order. Unlike other drugs that are in the REMS program, like in the pharmacy has to give a PPI handout, with Addie, you actually have to enroll to prescribe it, and the pharmacy has to enroll in order to dispense it. So enrollment form here, it says that you've read everything that's in it, and then the prescriber attestations, these are what you will be bound to legally, that you understand that it's only available through prescribers and pharmacies. Again, I'm not positive, but I think that may be unique. I don't remember it being elsewhere. Pharmacies have to register for other REMS programs, but I don't remember having to go through any training for it. I could be wrong on that. I understand that there's an increased risk of hypertension and syncope. I've reviewed the Addie prescribing information, et cetera, et cetera. You sign that, and then that allows you to register. With the pharmacy, pharmacies actually have to go through a training program, and even technicians that dispense it. Everyone in the pharmacy has to be familiar with it. And here is the patient. So this is the patient agreement. And alcohol use is contraindicated. Contraindication is one of those words that people love to throw around legally and then find an issue trying to explain it when someone says, what does contraindicated mean? You know, and the easiest way to say contraindicated is people who shouldn't take it. So if you match any of these conditions, then you shouldn't take the drug. So the patient has to, you see in this box, if I feel lightheaded or dizzy, I will lie down right away and seek medical help if they don't go away. If I feel faint, I understand I should only take Addie at bedtime. If I miss a dose, I will skip the dose. This is one of the more comprehensive agreements that you'll see in any other REMS program. And that really should underline the importance of the seriousness of that syncope and hypotension side effect. Okay, so we will close with Addie for now. We'll take a few minutes break. You probably will not see any pause in your the feedback of the CE, and I will announce when we start back, and we'll be back in just a few minutes. Okay, so we are back from the break and actually had a good question pop up about the REMS program and about Addie. And the question was, do patients need to be screened for pregnancy before given Addie? And that was brought up based on the REMS program with Accutane, which is a very good question and illustrates the difference between REMS programs and what they're for. Now, this REMS program has, it's in effect because of a very bad side effect and drug interaction with alcohol. Accutane, on the other hand, has teratogenic effects. So Addie, if you were pregnant and were having low sexual desire, you would not indicate, that would not be an indication for Addie because the pregnancy is more than likely the issue. That being said, if Addie was being taken, there shouldn't be any side effects for the baby. So if someone came in, was having low desire, didn't know that they were pregnant, you wouldn't do a pregnancy test before you prescribed it. They started taking Addie, come to find out they're pregnant, then you would just stop it. So that's a very good question. And on the other hand, if it was Accutane, you have to make sure that the patient's not pregnant because of the teratogenicity. So different REMS programs exist for different reasons. And I think that was a very good question in order to illustrate those two. Okay, so now we're going to move off from hypoactive sexual desire disorder and move on to osteoporosis. Osteoporosis is a major public health threat. 55% of Americans over 50 or older are expected to have it. In the USA, 8 million women and 2 million men are estimated to have osteoporosis. That is one of the more significant numbers that you'll see as far as conditions with the population. At-risk population is very large. So in addition to the people who have osteoporosis, the people who are at risk of it are very large. So osteopenic patients, 34 million Americans and 37 to 50% of white women are at potential for at risk for having osteoporosis. Treatment should be considered for men or women older than age 50 who have either a hip, vertebral fracture, have a T-score of less than or equal to negative 2.5 at the femoral neck or spine. Those who have low bone mass at the femoral neck or spine, and a 10-year probability of a major osteoporotic fracture based on FRAX. The RDA for Americans, or the recommended daily allowance for American adults, is 1,000 to 1,200 milligrams of calcium, elemental calcium, which is preferred source. Supplements are only added when the diet is insufficient. Vitamin D, 600 units, and for older adults, 800, with some organizations' guidelines recommended higher doses. Sun exposure, fortified foods, and supplements also help to bring these in. One of the questions that I get asked a lot in pharmacy is the different sources of calcium. And there's barefoot coral calcium, there's Mediterranean calcium, there's this calcium, there's that calcium. There's a different type of calcium depending on what salt that it is, but the coral calcium, the barefoot calcium, all this are pretty much advertising gimmicks in order to get, I guess, a different market. Calcium citrate is the best, no matter what form it's from. If it's calcium citrate, I have seen article after article and study after study, and they all boil down to calcium citrate. Anti-resorptive prescription medications, bisphosphonates, which we're very familiar with, the Fosamax, Beniva, Actonel, and Reclast, etc., are other treatments for osteoporosis. And then earlier we mentioned fortified foods. One of the newer trends today is almond milk. Almond milk doesn't have calcium in it by itself, but it can be fortified with calcium, even to the point of having more calcium than cow's milk. So when it first, I guess, became popular, it wasn't fortified. And then in order to address that, it was. A lot of times you'll have calcium citrate plus vitamin D, and that'll depend upon the particular prescriber and the patient. If they have a history of cancer and can't go out and get sun exposure, then they'll need more vitamin D. A lot of times it'll be written in elemental form, prescription-wise, just so that you can indicate what you want the patient to take. They can still bring that to the pharmacy, and then it can be sold to them over the counter. So rank ligand inhibitor, Prolia, denosumab, is another option, as well as estrogen agonist and antagonist. Evista, Vivant, and Aprila are three different options that have come about relatively recently in medicine. Calcitonin, you'll either see Miacalcin, Fortical, some of the others. They're nowhere near as popular today because of their effectiveness and because of their cost. And then also formation medication, recombinant human parathyroid hormone, and then Forteo is another, and we'll talk about some of these here. So several new drugs are actually in late stage in clinical development, and some of these are significant because of their issues. The medical officer at FDA, which currently at the time of this presentation is Marcia Whitaker, said providers should consider a duration of bisphosphonate therapy since it does continue to work for 3 to 5 years after you stop. They also have an FDA safety warning because of osteonecrosis of the jaw that has been in effect since 2002, and they've also been associated with esophageal cancer. So we're going to get some insight on some emerging therapies. So the BA058 or 058 ABL, which is in trials, inhibits cathepsin K, reduces bone reabsorption without decreasing the number of active osteoclasts, and thus preserves the promoting osteoblast function. Data from phase 3 fracture trials show that this agent is effective at reducing fracture risk. Progressive increases in bone mineral density have also been seen over 5 years. A study evaluated the long-term effects of ABL on bone mineral density and bone strength. This was done in aged osteopenic ovurectomized monkeys. After a 9-month bone depletion period, increases in bone markers and decreases in BMD by the DXA were observed in these groups consistent with estrogen deprivation. Treatment was then initiated for 16 months and evaluated. Daily administration ended up showing marked bone anabolic effects. The spine and femoral neck BMD was comparable to or above the pre-surgery levels after 4 months of treatment. So that was good. And it was sustained for at least 16 months after. Total tibial metaphysesis BMD was also increased at all doses with gains maintained at 16 months. So these were associated with increase in bone formation markers. As expected for these animals, decreases in bone mass was associated with decreased bone strength. And then also for the decreased lumbar vertebral cores and the vertebral bodies in compression. So it demonstrated the ability to rapidly build high quality new bone in monkeys with sustained gains over time and improve bone strength in clinically relevant sites. So once weekly, the odanacatinib, this is another investigational drug, which is once weekly. It's it's an oral drug and it's highly selective. Shows a robust effect in reducing fracture in postmenopausal women. However, small increases in numbers of serious adverse effects, including stroke, atrial fibrillation, and atypical fractures remain a concern. They had a long-term trial, the LOFT trial, which was double-blinded, placebo-controlled, and 16,000 women, 65 years or older, it showed that were diagnosed with osteoporosis. All subjects received weekly vitamin D3 supplements and daily calcium supplementation, and ultimately came up with a risk versus benefit. It was, as a matter of fact, because of that risk and benefit, they actually decided to go ahead and drop this particular drug. The risk for the stroke ended up being more significant than the benefit. And so the reason I bring this drug up and the fact that they have decided to stop, it was dropped actually in September of this year, September of 2016. And the reason I bring that up is it will still show up in many trials or many articles rather, saying that it has been an investigational drug and will probably show up for a year or two because it takes so long for drugs in investigational trials to go from investigational to actually being on the market, that there will probably be a fairly large overlap in information with this drug. So this drug has been stopped by the manufacturer, and that was stopped in September of 2016. So now we're going to switch gears and leave osteoporosis and go to menopause. In the previous iterations of this continuing education, I've had various practitioners in the room with me and tell me about some of the medications, homeopathic medications and herbal medications that they have used in the past, and some of the different success rates that they had. So I know most of you are familiar with herbal and homeopathic, but I think that this is the time that we need to talk about the homeopathics. Well, actually, we'll talk about that in a few minutes, but we won't talk about the difference between homeopathy and herbal medicine. So systemic hormone therapy with estrogen alone or in combination with progestin is the most effective therapy for vasomotor symptoms or hot flushes. Given the variable response to hormone therapy and its risks, of course, it is recommended to individualize care and then, of course, treat with the shortest course and the lowest effective dose that is needed in order to relieve those symptoms. So, of course, you have clotting issues as well as breast cancer and other issues that are with them. So it's actually led menopause symptoms has led to a trend of treating with alternative therapies. And we have some in here that when I was talking about our drug rep discussion at the beginning, this is where this is going to come into play. So we're going to focus on non-hormonal pharmacotherapy since HRT and ERT is a discussion in and of its own. So effective alternatives for vasomotor symptoms, Paxil, which is a brand name of paroxetine, as well as Paxiva and Brisdale. We'll talk about those. SSRIs, venlafaxine, or SNRIs rather, Pristiq, also catapress and Neurontin, which is gabapentin. During the course of delivering this continuing education, I found that gabapentin has been controlled in California for years. I did not know that. It is currently considered a controlled substance. Well, it's in Kentucky, the Cabinet of Health and Human Services are who determines whether a drug is scheduled or not. And it has been approved to be scheduled in Kentucky and will go into effect in July of 2017. So, and we'll get to that because there's some issues when considering using Neurontin. Estrogen therapy effectively alleviates atrophic vaginal symptoms related to menopause. So local therapy is typically what you like to do with either creams or vaginal inserts. So venlafaxine, brand names Effexor and Effexor XR, immediate and sustained release forms, which is the difference with that suffix. It is used for vasomotor symptoms and is off-label, but recognized as effective. This, when we had the foundation discussion earlier about what is this medication for, venlafaxine is used for depression, and it is used for other issues. It is off-label use for vasomotor symptoms. So when you prescribe this to a patient, they get their patient insert that they have to get from the pharmacy, and they're going to look at that, and it's not going to say for menopause. So it's important to tell them that this is, off-label, but recognized. So it's been recognized as effective, and it's more of a legal term why it's off-label, because no one has put the money into getting that changed over. It's been used observational for years and years and years. Initial dose at 37.5. Usual dose will be anywhere from 37.5 to 150 per day. Therapy is usually initiated again with that 37 to minimize adverse effects. Then as the patient becomes tolerant, you can titrate the dose up. Most side effects patients will start to become tolerant to after they've been on the drug for a few days or a couple weeks. Some of the adverse effects you'll see, especially when you're starting, is nausea and headache, insomnia or nervousness, dry mouth. All of these the patient should get tolerant to over time. And if you titrate too fast, they may start to experience these. You can back that down, go over a longer period of time or a little slower titration. Mild to moderate renal impairment, if they have a creatinine clearance of 30 to 89 mils per minute, extended release, you want to reduce that dose from 25 to 50%. If you're doing the immediate release, then you want to reduce by 25%. If it's above 90 or above, then you don't have to do any adjustment. Severe impairment, 50% reduction is required. If they're on hemodialysis, you want to reduce by 50% total. If they have liver impairment, if it's mild to moderate, reduce the total daily dose by half. If it's severe, by half or more. When you discontinue, you need to gradually taper this dose to decrease or minimize the incidence of withdrawal symptoms and allow for detection of reemerging symptoms. Hopefully you can transition during menopause on this drug, and then once they have gotten past, as you titrate down, if the symptoms don't reappear, then you know that you're where you should be. The APA and NICE guidelines actually suggest tapering over at least several weeks. This is really dependent upon your experience and the patient's particular adverse effects and how they respond. So you may need to taper more conservatively, just depending. Longer term treated patients, they recommend tapering over 4 to 6 months. Again, there's no reason to rush on this. It's not an expensive drug. It does exist as a generic, so there shouldn't be much cost associated if you wanted to taper over a longer period of time. Desvenlafaxine. So desvenlafaxine is Prestique, and this is one of the no longer new strategies that have been employed by pharmaceutical companies. Each drug exists in two forms, or enantiomers. And you have one form which has therapeutic effects and adverse effects. And then you have the other form which pretty much has adverse effects. Okay. One of the first ones that we ever saw that had actually utilized these properties was Claritin. Okay. What followed Claritin that was related to Claritin? Do you know? So Claritin's loratadine. What's desloratadine? Clarinex. Okay. So Celexa, what's related to Celexa? Lexapro. Right? Lexapro. And what about Prilosec?
Esomeprazole, omeprazole.
Nexium.
Nexium.
As a matter of fact, Nexium was billed as the other purple pill. Now, for practitioners, I want you to understand that there is, on paper, good scientific reasoning behind it, but the real reasoning behind it is patent extension. Okay? So, omeprazole, a PPI, proton pump inhibitor, and esomeprazole, the same thing, but it's the enantiomer. So you have your drug is oriented in levo and dextro. So you will have the levo, which is your main active ingredient that has your therapeutic effect and side effects. And then you have the dextro, which really just has the side effects. So if you separate these two out, you can keep the therapeutic effect and cut the adverse effects in half. Right? So Clarinex works just as good as Claritin with half the adverse effects. Lexapro, just as good as Celexa with half the adverse effects. Okay? Now that's what the drug rep will tell you. What the pharmacist will tell you is that one costs 50 cents and the other one costs $20. Because once they do that, it is technically a new dosage form. It's a similar chemical, but it has been separated out. So that allows them to get another brand name, extend that patent. And I realize that we are a capitalistic society, and without money, we will all die. But if a patient cannot afford to take a medication, then that's where we get into an issue. So desvenlafaxine is the isomer, and it is marketed as Prestique. It is used, again, as off-label. Initial dose is 100 to 150. One of the more important or difficult things to explain to patients is potency. Why 5 milligrams of one drug is the same as 600 milligrams of another. So don't get, even though that they're isomers of each other, don't get thrown off by the 100 to 150 milligrams versus the 37.5 and the 75. It does have no adjustment in renal impairment if it's greater than 50. If it's 30 to 50, you want to do 50 milligrams once daily. And if it's less than 30, 25 once daily, or you can do a 50 every other day. End-stage renal disease that requires hemodialysis, 25 once daily, or again, 50 every other day. Supplemental doses should not be given after the hemodialysis. Sometimes the dialysis will remove the drug. That's not needed here. Hepatic impairment, if there is mild impairment, you do not need to adjust the dose. Moderate to severe, 50 once a daily with a maximum of 100. Adverse effects are going to be very similar, but less often. The nausea, headache, somnolence, same side effects because it is ultimately the same drug. 25 milligram tablet exists, and it exists pretty much as a titration dosage form. So when you need a gradual reduction, you can use the 25 tablet because sometimes it is just difficult to split and get any kind of reasonable tablet after when you're trying to taper. So the 25 is not intended necessarily to take, but rather just to use if you're tapering someone off. Taper the same way as you do with Effexor. If it's intolerable withdrawal symptoms occur, then you want to titrate slower, go back to that previous dose, and do a more gradual titrate. Now, here comes one of my favorites that I like to talk about. And I like to talk about this because of the trouble that I might can potentially save you. Paroxetine has been around for a long time. Brisdale, Paxil, Paxil CR, Paxiva. We'll have different doses based on what brand name drug you have. Dosing in renal impairment, yes with Paxil, not with Paxiva, or rather with Paxil and Paxiva, but not with Brisdale. And hepatic impairment, yes with Paxil and Paxiva, not with Brisdale again. Adverse effects, nausea, somnolence, insomnia. Sometimes it's hard to, it's difficult to explain to patients that it kind of depends on how you're going to react. Some people might have insomnia. Some people might get drowsy. So, I'm sorry. Let's go back here. I thought I had another slide on that. We do not talk about PMDD in this particular continuing education. Okay. But PMDD, premenopausal dysphoric disorder, there was a drug called Seraphim. Are you familiar with Seraphim, either one of you? Okay. Seraphim, to those in the audience who may or may not be familiar, is a brand name of fluoxetine. And it came as a tablet instead of a capsule, which makes no difference whatsoever, but it is a tablet. And these little differences can be billed as the reason you should take this. So Seraphim come out when earlier when I used the alphabet soup and I talked about low T and HSDD and IBS and IBD. When premenstrual dysphoric disorder was first identified or became popular, I guess, in public, Seraphim come out. I'm not sure how long all of you have been practicing, but there was a revolution in pharmacy when the Zithromax Z-Pack came out. It brought unit of use to the forefront, and being able to prescribe what you need in a pre-packaged little pack with all your directions and everything. I'm not sure that either one of the people here will remember Tech Pack, Biox and XL packs, Tequin and Biox, and everybody come out with a pack because that was the popular thing. They have a pack. That right now the popular thing is to have a initial. You know, you can have incontinence or you can have OAB. Okay. And you get led around on the commercial with the little pink bladder that's actually really cute. But everything has to have an initial today, low T, HSDD. So when PMDD was more popular, they came out with Seraphim. And if you'll remember a few slides ago when I had Addie, the first of her kind, it almost makes her sound like a robot, a Cylon, if you will. And if you're listening and you get that, then I would give you bonus points if I could. But the first of her kind, well, when they came out with Seraphim came in a box with little pink flowers on it. And I mean, it looked really pretty and really feminine. And it was a dosing pack. And, you know, Prozac actually came as capsules. So fluoxetine and Seraphim came as a tablet. And it was indicated for PMDD. So if you don't ask the question, so Seraphim is indicated for PMDD. It's the only drug at the time that was indicated. So what's in it? Fluoxetine. So the same thing it's in Prozac, right? Right. Is there a generic to Seraphim? No. Is there a generic Prozac? Well, yes. As a matter of fact, it's on the $4 list. So if you go with Seraphim was like $40 or $50 to the patient. It was like $200 or $300 where you could get Prozac, and actually have a slide coming up to show some of the prices on these. So with the Brisdale is another one of these drugs that comes up and tries to they're taking a lower dose of paroxetine. Paroxetine has been on the market for a long time. They've actually lowered the dose down to 7.5 and 10 milligrams, and that gets it just under the threshold of not needing dosing adjustment in renal or hepatic. That being said, you could take a Paxil a Paxil tablet and either cut it in half or dose it every other day, and you could still get that same effect without having to pay for a brand name drug. So I think that's important because it could actually have a negative impact on the patient and how much they have to pay by not, I guess, going through the drug rep trickery, if you will. So Tibolone is actually a selective tissue estrogenic regulator. It is a synthetic steroid. It has tissue selectivity, has progestinic and some androgenic as well as estrogenic effects. Tibolone itself has no biological activity, but its effects are a result of its metabolites, which is similar with a lot of drugs. It has estrogenic effects on bone and vaginal tissue, as well as been used as an alternative to estrogen replacement therapy in Europe for at least 20 years. Typically, I don't bring up drugs that are used in other countries, except for the fact that this one has been considered coming to the U.S. for some time. The brand name is Livial. It's not available in the USA yet, but they have been trying. I'm not sure what the holdup is, but they've been trying for a couple of years to get it approved through the FDA. It could be used for prevention of postmenopausal osteoporosis. That's for hot flushes as well as the associated night sweats. improvement in bone mineral density in patients with established postmenopausal osteoporosis and who have contraindications or intolerances to first-line therapy. So it's not recommended during the perimenopause period because it may cause irregular bleeding, but this is a drug that I think could have potential effect on prescribing habits coming up in the future, and you've heard it here first. So now we're going to get on to gabapentin, which has quickly become a scourge in my area of practice and across the country. Gabapentin or Neurontin, it's a prevalent drug of abuse. I'm sure most of you know that. It seems in the previous 2 times that I've given this talk that several people were unaware that it was being abused. Its effects vary with the user and the dosage, their past experience, as well as their psychiatric history and expectations. Patients will actually have euphoria, sometimes improved sociability, marijuana-like high, relaxation, a sense of calm. Now, when I say that it varies with user and dosage and past experience and their expectations, sometimes people expect to have an effect and then they'll have it. And that's called the placebo effect, which we're all familiar with. So the more that it's not advertised, but the more common knowledge it becomes that you can abuse the drug, sometimes the more people will have an effect. Not all reports are positive. Some people actually say that it zombifies them to the point that they can't think or can't hardly move. In primary care, an increasing number of urgency of prescription requests cannot necessarily be explained by the increased number of causes of neuropathic pain, which is a big indicator that it's being used for something other than what it was prescribed for. Street names, Gabbies, Rontons, Ronts. In my clinic, we actually require a ID the same as we would for a controlled substance. And we have a diabetic center of excellence, so we will actually have patients that come to our clinic specifically for the diabetes center. And with your prescription drug monitoring programs, in Kentucky it's called CASPR, but with your prescription drug monitoring programs, they only monitor those drugs that are controlled. And in most places, gabapentin is not controlled. And because it's not controlled, you can't trace it. So we're finding a major issue with that now. And as more and more states control this drug, then we'll see that usage go down. Another issue is the fact that it's relatively cheap, which doesn't help. So gabapentin, it can be used and it is effective. Just keep in mind, especially if someone comes in and asks for it, that's a red flag. If you choose to use it as an adjunct, I would, even if it's not controlled in your area, I would still treat it as a controlled substance. Okay, this is just a good algorithm for the pharmacologic management. I like algorithms because they help. I'm a visual learner, and this helps to put things in a visual pattern for me to be able to see. If you have menopausal symptoms, yes, then we can go to urogenital symptoms only, or if they have vasomotor and urogenital symptoms, and that takes you down a different pathway. If they don't, then if the woman is at risk for osteoporosis, that'll put you in one way, and if they actually have osteoporosis, that puts you in another. So again, this is a good little algorithm that you can look at and kind of line what you already know. So Brisdale, which we talked about briefly earlier, is the only non-hormonal prescription treatment option proven to reduce moderate to severe hot flashes or hot flushes during menopause. So they're less frequent and less intense, and a nightly dose typically provides 24 hours of relief. So it is FDA approved, and it is proven safe and effective. In pharmacy, I talk about a lot of things, especially in this things that are hard to explain, because we can explain the things that are easy to explain. But when things are proven, have an FDA indication, that's easy to explain. But Brisdale is paroxetine, but only Brisdale has the FDA approval. Paroxetine does not. So paroxetine has been on the market for years in 10 to 20 milligrams. Taking a 10 milligram every other day would surely be very similar to taking the 7.5 Brisdale. And there's nothing wrong with Brisdale other than the fact that you have this increased associated cost. So the Seraphim that I told you about earlier and the Brisdale, cash price for 30, it's 154. But if you were to go, products are already on the market for Seraphim, you're talking $4. Cash price for Brisdale, $404. Or if you was to go with Paxlovid generic paroxetine, again, $4. The infamous Walmart $4 list is slowly dying, but still these are cheaper drugs, and this is a way that you can help the patients and get them the medication that they need, or get them the relief that they need without being a financial burden. Okay, now we're going to move on to herbals and homeopathy. So if you don't have a good handle on the two, we'll talk about it briefly. If you do, then you can relax for a second. But herbals versus homeopathy. Pharmacy is based in herbal roots. There are a lot of medicinal plants. We're familiar with, estradiol or estrase that we mentioned earlier. 50% of it is synthetic. 50% comes from soy or yam. We have chemo medication comes from the bark of Pacific yew. There are all kinds of herbal medications that are still in use and have had a long history for thousands of years. I think the ancient Egyptians 5,000 years ago used aloe for burns. So herbal supplements, though, have not been subjected to the same scientific scrutiny and aren't as strictly regulated as medication. Would any of my on-site audience like to tell me why herbals are not studied any more than they are?
Money.
Well, I have one cynical attendant that says money. And he's absolutely right. So this is, again, I believe in being very realistic, but we live in a capitalistic society. And if money actually drives innovation. It just does. And some people are unaware of this, but you cannot patent a natural substance. You can only patent something that you have created. And herbal products by nature are natural products, so they can't be patented. So if I was to take in partnership with two of my friends and take St. John's wort, for instance, and study it for safety and efficacy for depression. Now, I know many of you have probably prescribed St. John's wort or recommended St. John's wort, and I'm not saying anything against it, that it does or does not work. But let's just say that I sink in $500,000 of my own money, and we prove what we've known all along, that it is safe and it is effective, and then I create Carter's St. John's wort, and then everybody rips off my formula, takes my research and sells it, and I make nothing. Now, the problem with that is that takes away the incentive for anyone to study it. One of the largest databases, and you can look this up online, is a German compendium of herbal medications. And the German government had actually studied and compiled a lot of monographs on herbal medications because the government had actually paid for that to happen. So we like to be in a society where everything is equal and we do everything because we should and people want to, but ultimately, if people are not making money on the product, then they're not going to research it. So they haven't been subjected to that same scientific scrutiny, and that's just the cold hard truth. FDA approval is not needed for medications. Herbal supplements are regulated by the FDA, but not as drugs or as foods. They are as a dietary supplement. Manufacturers don't need FDA approval before putting them on the market. They have some basic regulations, like they have spiders in them. They can't kill people. But other than that, the burden of proof is very low. Before we move on to homeopathy, herbal medications have to have a statement on the side that says that this has not been proven. This statement has not been approved by the FDA. So they can't say that herbal medications treat or cure anything. What they can claim is that it's been used for this. Okay. So green tea, been used in China for cancer prevention for thousands of years, versus green tea prevents cancer or is useful for cancer prevention. So they can't make those statements, but because it's written on the side, people don't pay that much attention to it. And then there's this assumption that in the United States, the powers that be would not allow something to be put on the market that's not safe. And what they don't understand is that this statement's not been evaluated by the FDA pretty much negates that. So again, not saying that the drugs are not good or that they don't work, but they don't have the same scientific scrutiny and they've not went through the same processes as other drugs have, and that's for that reason. So now we'll move on to homeopathy. Homeopathy is based on a centuries-old belief that like cured like. Some people may be familiar with, have you ever heard hair of the dog? Have you ever heard hair of the dog?
Through you.
Through you. Through me?
Yeah.
Okay. You may or may not be familiar with a Bloody Mary is called a hangover drink. It's a drink that after you've had a night of drinking, you drink it in the morning, and it's supposed to make you feel better. Part of the reason is because it has alcohol in it. So, as we all know, when the body metabolizes alcohol and continues to metabolize it, makes the aldehyde products that make us feel so bad. If you give it fresh alcohol, it'll leave that alone and go to the fresh alcohol. And so you essentially are titrating yourself down is what you do. But hair of the dog phrase, and if you might see it in a movie, here's hair of the dog, and then they'll take a shot. Hair of the dog referred to an ancient belief that if you got bitten by a dog, if you consumed hair from that dog, it would prevent you from getting rabies. Do you know anybody that's ever been bitten by a dog? Have you ever been bitten by a dog? But did that person didn't get rabies? Did they get rabies shots? The answer is no, and then one yes.
Yeah.
So the thing is that they had consumed hair from that dog and didn't get rabies, then that just proves that it works. Okay? So like cures like. If a substance in a large amount causes a certain disease, then that substance in a small amount could cure the disease. And I don't mean to step on anyone's toes when it comes to homeopathy, because some people are very passionate about it. But the idea is that the body knows how to heal itself with its basic programming. It just needs the instructions, so to speak. So if disease is actually a dysfunction of the body's ability to cure itself. So if you administer a diluted form of what would be a toxic substance, you can actually give the body the stimulus that it needs to heal itself. So the more dilute the substance, the more potent effect it would have against a given disease. Okay? So homeopathy related to the law of infinitesimals. The preparation of a product has a stepwise dilution process. So each dilution is succussed or shaken vigorously. The point of that is when you shake or succuss that dilution, it leaves behind the image, the essence, the spirit of the original drug in the water. The more that's repeated, the more diluted that it is. And then the more diluted that it is, the more potent that it is. Okay? So what you're doing is you're taking an actual poison or toxin, dilute it as much as possible until you get the essence of that drug, and then you use that to teach the body how to heal itself. Okay? So dilutions of 1 to 10 are signified by an X. So if it's 1X, it's a 1 to 10 dilution. 2X, 1 to 100, 3X, etc. Dilutions of 1 to 100 is signified by a C. So if it's more dilute, is more potent, then the bigger the dilution, the stronger the drug. So you'll see 1C, 2C, 3C, and those indicate that they are more potent. So a good example would be take a gallon of water and take a teaspoon of drug and put into the gallon of water and shake it up. Then you hit the jug multiple times. Then you take a new teaspoon, get a teaspoon of water from that jug and put that into another jug. And then repeat the process again and again and again and again and again and again. The optimal, at one point, this may not be accurate anymore, but at one point, the optimal concentration of a homeopathic medicine was 1 teaspoonful of drug inside the volume of the earth. And that is that is the essence behind homeopathy. And I actually had a patient come in and ask me once she was having menopausal symptoms, and during the late 90s, which was right after I had learned that you was to take HRT for the rest of your life, Prempro, if any practitioners listen to this, remember Prempro, also a fad with after the Z-Pack, it come in its little. So she was concerned with taking estrogen because of cancer risk, and she really didn't want to take it. And someone told her that she could take phenobarbital for vasomotor symptoms. Have you ever heard of phenobarbital for vasomotor symptoms? As a matter of fact, it exists in a drug called Bellargal, belladonna, and the tablet was actually a psychedelic tablet. It looked, it was multiple colors, but one of the ingredients in it was phenobarbital, Bellargal, belladonna phenobarbital. So this basic knowledge made it out to this person that you could take phenobarbital, and she wanted to get some, and I informed her, is phenobarbital prescription or not? Yes, it is prescription. So I told her she had to have a prescription. Their response was, no, my friend said I could buy it over the counter. So I explained the difference between prescription and whatnot. So she gave me the look that she didn't believe me. And then she left. So she comes back like a week later and it's actually 2 days later. Because she came back and wanted to show me what I had missed. And if you've ever seen the little tubes of ibuprofen that you can carry in your purse or your pocket, it was like a little chapstick tube. And it said phenobarbital. And it said Rite Aid on it. And it had a barcode on it. So, so I looked at it and I thought, oh my Lord. And so I turned around and it says phenobarbital mecum something. I'm sorry. You'll see what I'm talking about here in a second. And then it had 2C on it. And I said, oh, this is a homeopathic phenobarbital, which means there's actually no phenobarbital in it. The dilutions get so dilute that using Avogadro's number, there's not actually a molecule of the drug in the solution. So the reason they were able to sell phenobarbital over the counter because there really wasn't phenobarbital in it. So I explained that to her, and she still kind of gave me the "I don't believe you" look. And so she left, and then she come back a week later with a prescription for estrace. And I understood, and I realized that she needed to exhaust what she needed to exhaust, but ultimately that was the deal. So you can see some of these things over the counter, and what they'll do is they'll stick things like, if you'll look over on the King Menopause here, and this is just something I picked. This is King Menopause spray. Okay, so you see the Firmum Metallicum. That's supposed to be a form of iron. Firmum Metallicum. A lot of them end in IUM. Sulfuricum. Area. ELA. They'll stick that on the end, and you can see here an active ingredient in 10 times, 30 times, and then LM1. So that shows you that it is homeopathic. And if anyone watching and taking this continuing education is a strong proponent for homeopathy, I apologize, but there's no medicine in homeopathy. So it's almost more of a belief than it is a treatment. One of the ladies that attended the last continuing education actually had a homeopathic product that she used for vasomotor symptoms, and it worked with patient after patient after patient. And I told her of one that I had to agree that after you hear so many patients say that it works, you have to, if it's placebo effect or not, they say that it works. So if a patient is adamant about taking it, then that's one thing. But there's actually no medication technically in the homeopathic medicines. So Warmy is actually a kind of a heating pad that you can use to place on the abdomen. And it actually, Warmy, see, let me make sure, I'm sorry. There's a Warmy pad, and then there's actually a supplement that you can take. And then that will have calcium in it and some of these other ingredients that you can see. For the most part, there's no proven effect with that. Probably the effect of having the warm heating pad on the abdomen to help reduce cramps or anything else is probably as much as you'll get from that. This will actually conclude the continuing education segment. Again, there is a link for questions if you want to submit any questions for the group to see. And then my contact information is listed up here, and you can email me if you have any questions on that. I thank you very much for your attendance. I welcome any questions and comments and feedback that you have. And if you want to communicate with Frontier Nursing about any potential future topics, please let them know and they'll get with me. Thank you very much. You have a good day.